everyone. I hope you're having fun chatting and getting to connect. We are going to start resuming our schedule. I feel like such the mom right now. So please find your way back to your seats so that we can begin our next informative panel, Pain Management with Alternative Interventions panel. We'll just give a minute more for everyone to come back. Okay. As many of us know all too well, endometriosis can cause debilitating pain that intervenes with our daily activities as well as causes havoc to our body. Today we have an esteemed panel of pain management experts to discuss possible ways to manage your endometriosis-related pain. Erica Michitsch, a doctor of physical therapy with a specialty in endometriosis and a co-owner of Solstice PT in New York. Lexi Burtman, also of Solstice PT, who also has a specialty in endometriosis treatment. Dr. Gerald DeGregoris is a pain medicine specialist and has his own pain practice, chronic pain practice in Midtown Manhattan. We also have Mila Mintsis, holds her doctorate in acupuncture and specializes in pelvic floor dysfunction and pain management through her office in Manhattan. And Mindy Pickard is an acupuncturist at 3 Treasures Acupuncture, also in Manhattan, and specializes in pelvic pain and pelvic floor dysfunction, fertility, and pregnancy. Thank you all for being here. So I am standing, so sorry it's a little awkward, we ran out of chairs. Let's start with understanding pelvic floor dysfunction. What exactly is it?
Hi everyone, I'm Erica. It's an honor to be here and answering your questions. And so pelvic floor dysfunction is the pelvic floor muscle, and it's either being not functioning as it's properly should, right? So what we see in our clinic and related to endometriosis is that the muscle tone in the pelvic cavity might be hypertonic or not coordinated properly, and it could be affecting nerves and blood flow, relating to bladder, bowel, and sexual function, and orthopedic function. So we are generally treating that. Do you have anything to add, Lex?
No, but just listen. That, pelvic floor dysfunction can be spasms in the muscles, and they can fluctuate around your period, around ovulation, and highly tied to hormones and endometriosis symptoms.
How exactly does endometriosis and pelvic floor dysfunction correlate?
So pelvic floor dysfunction can be secondary to endometriosis, or it can come before, but basically with endometriosis, what we're seeing is that so in just a general term, when patients are in pain or chronic pain and they're clenching, they might clench their bodies, or if you're feeling, even if you have a headache, you might be super tense in your bodies. So someone with endometriosis, if they're having pain for long periods of time, you're in that area in your pelvis, you might subconsciously clench the area. So in orthopedic terminology, the pelvic floor muscle might start spasming, like Lexi said, have trigger points in it, and cause pain all throughout the month and not just during your cycle. So it could happen afterwards. Or for years of having endometrial pain, you could start having pelvic floor symptoms. So anything to add on that?
And as well, so if there's endometriosis on the bowel, on the rectum, in the vaginal canal, that can also cause a lot of pain. So we can work on the muscle as much as we can, but sometimes the endometriosis is still present there and it will still cause pain throughout.
Yeah.
I think another thing that's worth considering is inflammation globally as well as specifically. So we've observed that patients with endometriosis have not only focal areas of inflammation, but sort of global areas of inflammation as well. So endo can cause pain by several mechanisms. It can directly invade the pelvic viscera. It can also invade or become part of or embedded onto the bowel wall, which can cause pain, which is located near these viscera as well. It can affect the nerves and directly affect the nerves in the pelvic area, which can also cause pelvic floor dysfunction. And then we've also observed that people with endometriosis just tend to have more inflammation other places as well. So there's a rule that I think we've observed, which is that inflammation anywhere can make inflammation worse everywhere. So if someone has an endoflare, they may also find that, hey, their old orthopedic shoulder injury or hip injury also acts up on a similar cycle. So there's a couple of different mechanisms by which endo can cause not only pelvic floor dysfunction, but also other forms of dysfunction as well.
And just to piggyback on that, so say a patient comes into our clinic and they're coming in with bloating and constipation and painful bowel movements, right? So what we're seeing is, okay, this patient comes in and that kind of sounds like irritable bowel syndrome, right? So we treat it, we're treating the symptoms that we see, but these patients may also have endometriosis. So irritable bowel syndrome is also an inflammatory condition, right? And that can also be tied with endometriosis. So we're treating the pelvic floor muscles in the bowel region as well, which could be limiting bowel function, and it could be caused by endo.
So what exactly is pelvic floor physical therapy?
So pelvic floor physical therapy is an examination of all of the pelvic floor muscles and all of the muscles and bones involved. So the entire pelvis, the abdomen, the hips, the sacrum, the tailbone. So we'll do an evaluation on how all of that is affecting your pain and what symptoms are going on. Are there bowel dysfunction, bladder dysfunction, or sexual dysfunction? And then we treat what we find. So, if you're having bladder frequency or bowel urgency, we work on techniques to minimize that. We see the role the muscles play in that, and we teach new habits and techniques to decrease your pain and alleviate your symptoms.
Yeah, so we do a lot of daily education and, like Daphne was saying, routine change. So what's going on with your bladder habits, right? How much frequency do you have? What are you drinking all throughout the day? When is your bladder pain? If you're having bladder pain, when is it the worst? When is it better? Typically, like we might find with a patient with endometriosis, they might have more bladder frequency and urgency and pain during ovulation or during their period or a little bit before. So we're working on things like that. Then we're doing bowel habit retraining as well. And then with sexual dysfunction, what we'll see is if a patient is having pain with intercourse, we're doing a lot of treatments to help with dilators, to help stretch, decrease sensitivity in the area, change positions, positioning with sexual intercourse, things like that. Also, we treat a lot of, and like what Rachel Rose was saying, we treat a lot of like anorgasmia or pain with orgasm. So we have a lot of techniques that help with that. And especially patients with endometriosis that have adenomyosis, they tend to have more symptoms like that. So we give different techniques to help with those symptoms.
And then I think also just, as physical therapists, someone comes in, we treat them, we work on them manually, we do exercises with them, but then ultimately we're teaching them how they can manage their symptoms at home and without us, whether it's manual or exercise. So we're really trying to build a toolkit for the patient to have so that when they are in an endo flare, they are in more pain, they know exactly what is causing it and what they can do to alleviate it.
And in terms of pelvic floor PT, what are some of the techniques that are used? Because I know that there's a little apprehension when you go to a pelvic floor PT. It's not as normal as, let's say, or as I should say, in the mainstream as it is when you hurt your elbow or your knee.
Yeah, so we generally check external first, and then we do check internally, vaginally, and rectally. However, if the patient is not comfortable with it, a pelvic floor PT should never be pushing that on a patient. The patient needs to practice desensitization techniques. They need to work on external first before internal work. So every patient's different. Some patients are totally like fine. Oh, check me internally, no problem, I'm fine. Some patients, you have to wean someone into it, and you might not even get to that point. They might have to do it themselves, and we give patients, depending on their history, it could be trauma-related, it could just be pain-related. We have patients, like if we're using dilators with a patient, which is like a medical device that stretches the vaginal opening, we will have the patient insert it themselves. Like, we're not necessarily inserting it. So we like to give the patient control over their body and what in what we're doing, right? So that they're the boss, the patient, really. So what was the original question?
The original question is how the techniques are used in PT therapy.
Okay, so basically what I want to say was that we don't like force anything on anyone, but technically, if we're doing internal work, we do a lot of myofascial release. If there's tension in the muscle, and we do coordination training, can you relax? Can you engage your muscle? Can you bear down? And this is all related with bowel, bladder too. Like, can you bear down properly to have a bowel movement without straining the muscle or straining the nerve and causing more symptoms? Can you contract to hold in your urine? There are techniques to contract your pelvic floor to push off having an urge to urinate. So we do a lot of coordination training as well. But specifically with endometriosis, we do a lot of visceral mobilization, which is where we're working along the bowel lines, the uterine lines, in the abdomen, and we're doing a lot of myofascial work on the abdomen to help get rid of any adhesions that could be there. We do that pre and post surgery, and a lot of scar tissue mobilization. Do you want to add to that?
We'll do also like pain management techniques, teaching proper breathing, teaching diaphragmatic breathing, working on people's diaphragm, and working on their nervous system, and teaching them how to downregulate and how to kind of use their breath to control their pain.
You mentioned something about post-op PT versus prior. What's the difference? And can you treat someone who is preparing for a surgery? I know it's like a three-part one, but
No, we really like seeing people pre-surgery because if we go through kind of what their recovery might look like, what the surgery entails, some extra questions that they didn't get out when they had their surgical consult, they're able to ask us and just kind of prep them more for surgery.
Yeah. So and with pre-op, it's really nice to come in because I think it could help limit. I think we give techniques like you could do we can give you like certain supplements to take after that could help with adhesion, certain stretches, how long to expect to be out of work. So I feel like there's like a misnomer about that too, and we want patients to be like fully prepared, like, okay, I took this amount of time off or this time off from school, so it's not like a shock to them. We like to prepare pain levels. And a lot of bowel regimen so that they're not constipated after surgery as well. We like to work on that.
And then post-op, it kind of depends on the surgery that they had and then the extensive of it and what their surgeon said they're cleared to do by the time they come in. But usually we'll start with deep breathing. We can do scar mobilization, work on the abdominal scar, go over their bowels, and then just any symptoms that are still present. We work on those.
And we do, a lot of abdominal work, which I think makes a huge difference, especially because a lot of times with the endo excisions, they're doing appendectomies too. So when you get your appendix out on the right side, there's a lot of, I'm sure many of you know that's had the surgery, there's a lot of adhesion there too. So we tend to work on a lot of abdominal work. Yeah, and some nerve, and we've had a lot of patients with some nerve symptoms that had before and after, and that could be sciatic versus like a hypogastric nerve versus pudendal nerve pain. So we do a lot of nerve gliding and things like that to get the nerves to move better in the tissue.
And transitioning from PT to acupuncture, how is acupuncture able to alleviate symptoms of endometriosis?
Does this work? Hi, everybody. Does this work?
Yes.
I'm Mindy. One of the key things that acupuncture does is that it downregulates the nervous system. Many women who have endometriosis, of course, your nervous system's going to be really riled up. You're in pain. you're worried, you don't know what to do, you've seen a lot of doctors, so that's the first thing that I try to do is downregulate the nervous system. After that, I try to work on the local area to help with pain management. And then thirdly, sometimes I use herbs to help with the symptom management. Mila, what about you?
Yeah, so just to add, so when you're looking at endometriosis, you have to think about, what it's doing to the central nervous system. So just like, what Mindy said, and then you're looking at the local impact. And that could be, the adhesions and everything else that has been mentioned, nerve pain, local inflammation. And I find just from personal experience that for the local treatments to hold, you really do have to focus on the central nervous system. And then a lot of the times, once there is a lot of central sensitization present, which means the pain signal is just overfiring and your nervous system is upregulated. And a lot of the times that leads to it's called sympathetic dominance. So when we are stuck in, if there are physical symptoms that have been present for a long time and, specifically pain, and a lot of the times there are emotional symptoms that come with that as well, our bodies get stuck in the fight or flight mode, and it becomes very difficult to switch to the parasympathetic mode. And if you're stuck in that mode, it actually intensifies all the physical and all the emotional symptoms as well. And if you don't take your body out of that, sympathetic dominance, then it's just going to be really difficult for those symptoms. They do get better, but it's just every time you're exposed to something that is stressful or a memory from the past comes back or something else happens, the symptoms tend to come back. So with acupuncture, it's one of the modalities that is really good for treating sympathetic dominance, because for the body to be able to switch to the parasympathetic mode, one of the ways to do that is to stimulate the vagus nerve. And the vagus nerve is probably one of the most, in my opinion, important nerves in the body, because it's responsible for the calming function in the body. And then, it slows down our heart rate, suppresses inflammation, increases peristalsis in the stomach and the intestines. And the problem with the vagus nerve is the fact is that, it's deep in the body, and it's not easy to access it. But there are actually two spots where you can come close to stimulating it, and that is one is, it's in the ear, that is the auricular branch, and then also the neck. So by doing auricular acupuncture and stimulating the vagus nerve in the ear, and then actually treating SCM, which is the front of the neck, you're able to stimulate that vagus nerve, which helps to promote that parasympathetic balance and allows for the body to heal, basically, because then your body is able to be longer in that rest and digest state, and that's what helps it, to get better. It gives it that environment where your body can actually heal physically and mentally.
Thank you. Yeah, and just to piggyback, so we as PTs love to work with acupuncturists because when a patient with endometriosis comes in, there's so much trunk inflammation and bloating, and it really limits the way the diaphragm descends in the cavity. So, for Lexi and I, we're working on the diaphragm muscle externally, and we're mobilizing it so that it moves better, so that the whole trunk moves better and flows, and there's less bloating, and they'll call it like abdominophrenic dyssynergia and all these other terms. But basically it's like your diaphragm is stuck, and then it's not allowing it to when your diaphragm moves, the pelvic floor moves, and when your diaphragm's stuck, the pelvic floor stays stuck. But when the acupuncturist too, and I know Mila does specifically, you'll do diaphragm work, like you'll do needles all along here.
Diaphragmatic. Yeah, for diaphragmatic restrictions, you can specifically needle for that. Mm-hmm.
Yeah, so it just...
Yeah, and then basically the two modalities really complement each other. And also with, needling, you're basically, with endometriosis, as has been mentioned already, there are a lot of myofascial restrictions. And a lot of the pain that a patient can feel can actually come from, the actual adhesions in the organs. And then also our bodies physically, the muscles respond to that and form trigger points. And those trigger points themselves can actually create a lot of pain, and then they disrupt the proper function in the body, and that can have an effect on the organs. It's a cycle that, one affects the other, and then the myofascial can have the restrictions in the organs, can cause the, improper functioning of the organ. And with needling, you're actually, so to break that cycle, you need to, it's called deactivating trigger points, so fixing the myofascial restrictions. And these patterns actually, they take time to develop, but unfortunately, it takes time for endometriosis to be properly diagnosed, so it gives it time to develop, basically. And then, so a lot of the pain can be managed by just, deactivating these trigger points and restoring proper myofascial function in tissue. And, myofascial compressions can also cause nerve irritation as well. And with needling, with acupuncture, what it allows you to do, the beauty of it is the fact that, is that you're getting past the skin level and you're getting into whatever structures you need to address. So it basically lets you to get in a little bit more. And when you're doing that, you're increasing blood flow to the tissues, you're decreasing inflammation, you're, restoring proper function, and that's how it allows for things to get better.
The other thing that we can do as acupuncturists is post-op, we work on scar needling. So we horizontally needle underneath the scar to get rid of the adhesions. And that also helps with what the PTs are working on.
Yeah, and it allows you to get in more, right? Because the scar tissue is not only what you see on the outside, but a lot of the actual damage is deeper in and deeper inside, and needles allow, it might sound scary, but it's actually not that painful. It's a pleasant procedure in a way, but it allows you to get in deeper into the tissues and break down those adhesions in the scar tissue. Yeah.
The needles are very fine. They bend easily.
I guess you have to experience it to get over your fear, right? And then once you're okay. But we're talking so much about pain and endometriosis, but why, Dr. Jerry, does endometriosis cause so much pain? What is the culprit?
Well, there's a couple of mechanisms by which endo can cause pain. I alluded to a couple of them in my early response, but there's sort of a couple of broad classes of pain. We think of ordinary nociceptive pain is probably the most obvious sense of pain, and that's one aspect of the pain from endo. So nociceptive pain is typically sharp pain. It's well localized to a specific area. It's the pain that most of us deal with on a daily basis when we accidentally stub our toe or back our arm into a wall or something like that. You accidentally hit your thumb with a hammer. It's pain that's conducted by pain receptors for impulses which are usually supposed to be painful. So much, but not all, of post-surgical pain is nociceptive. It's transmitted by pain receptors, or nociceptors, whose evolutionary function they've evolved to teach us how to use our bodies appropriately. The theory being, if something hurts, if I hit my thumb with a hammer, well, next time I'll be more careful with that hammer, right? So that's nociceptive pain. And ordinarily, nociception is supposed to be temporary. So once I do strike my thumb with a hammer, okay, I've learned my lesson. A small amount of pain is adaptive in the sense that it teaches me how to use my body and how to not abuse my body. But what happens when nociception persists beyond to a point where it becomes maladaptive, where it's no longer teaching me what I should and shouldn't do, it's inhibiting me from doing other things that I need to do. Maybe it's making it so that I can't walk well, that I can't focus on my job or take care of my family. So nociceptive pain and other forms of pain as well sometimes last too long and then become maladaptive. And that's really where all these people on the stage come in, each of us with our own sort of facets to it. So that's one component of pain. And the reason why pain can sometimes persist too long is by several phenomena, but one that I think is instructive to consider is this wind-up phenomenon. So when nociceptors fire, when we hurt ourselves post-surgically, for instance, there are components of the spinal cord and the brain that sort of come into action and to start to dial down naturally that instinct of pain. So they'll tone down the sense of pain. But sometimes, for a variety of reasons, that natural pain alleviating system becomes impaired over time. And people don't understand exactly why that happens. But in some people, it happens more than others. So we lose our body's own innate ability to decrease pain, to damp down our pain. One of the things that can decrease our own ability to damp down pain is chronic exposure to opioids. So we know that the body has natural endorphins, natural opioid that get secreted after people have pain. So if you hurt yourself, your body, your brain will secrete opioids to help control and decrease that pain impulse. But when people are exposed to opioids on a chronic basis, day in, day out, your body loses that ability to produce our own endogenous opioids. That's one example of when pain that ordinarily would be short-term can become long-term if our body's own natural pain damping mechanisms are impaired. Another reason why pain can become chronic or maladaptive is if we get this component called wind-up. So there are a couple of components of the spinal cord that, for reasons which I haven't figured out yet, and a lot of other people haven't figured out yet either, can sometimes serve to amplify pain. And this wind-up phenomenon serves to have a positive feedback, whereby when a nerve receptor fires and sends a pain signal, it then, the spinal cord then sensitizes that nerve cell, that nerve pathway, so that it becomes more likely to fire tomorrow. And that is called wind-up. And there are several ways that we can treat that wind-up. So there are some novel drug classes of calcium channel blockers. So drugs like gabapentin are thought to affect this wind-up phenomenon. Drugs like ketamine are thought to affect this wind-up phenomenon. So treating wind-up is another potential target that we have to try and prevent pain from becoming chronic, prevent pain from becoming maladaptive. And then another thing that we often do, and that I spend a lot of time thinking about, is trying to use interventional procedures, needle-based procedures, to try and break this cycle of pain. So if we can temporarily anesthetize one of these nerves that is firing, in our opinion, too long and inappropriately, we can sometimes break that cycle of wind-up, where the spinal cord then gets a chance to almost like reset, and these peripheral nerves can reset. And sometimes when the local anesthetic wears off, the nerve is not quite as hypersensitive as it was before. And I find that some of these procedures that I do that are really aimed at breaking this positive feedback cycle of pain work best when they're used in concert with the other techniques that you've heard about from these four professionals to my left. I think they work really well when used, within a few days, or maybe even less, depending on the style of each practitioner, of adding acupuncture and adding pelvic floor PT. And I'd love to hear from the other four folks on the stage as to what the ideal timing is in terms of, let's say a patient has some pain, gets a block from me, how soon do they then like to then apply treatments? Because I think patients tend to like to focus on one thing. Some patients really want to focus on one thing at a time. That's what we do in life generally, but I think that if we can all work together, we can make more of a dent. So maybe I'll just pass the microphone over and see, if I were to do a block on Monday, how soon would you be interested in doing, a treatment?
I would be okay with doing a treatment on Wednesday or Thursday. I would give it at least 24 hours. And I say that with all modalities. I try not to have people do more than one modality in a day if they can help it, unless they're coming in from some faraway place. I think the body can, take just so much and more.
I would say, I don't know if you would say the same, Lexi. I always say 2 days if we send for an injection, I would think. 2 days, just because allowing some of like the anesthetic to wear off, right? And then we'd see them. And generally, just for you all to understand, like if Lexi and I have a patient that we're seeing for 8 to 12 weeks, and they have that wind-up phenomenon that you're saying, and we feel like there's a lot more like nerves firing in the area, and the muscle tissue actually feels much more healthy than when they originally came in. We'll say, maybe you should see Dr. DeGregoris and have him assess you, because you might benefit from getting a certain level of your spine blocked, which could help just stop the nerves. I don't know if that's how you would describe it, like stop the nerves from firing in the area, But yeah, just to kind of like calm the area down so that you could have a sensation of having less of that nerve pain going on, and retraining your brain. So we definitely depend on physicians like Dr. DeGregoris to help piggyback what we're doing if it's not necessarily getting rid of that specific pain that they're having. But 2 days is the answer, I would say, for us.
I'm actually a little more conservative, and that's because in case, it doesn't happen often, but if there's an adverse reaction, and if you have more than one modality, more than one treatment done in the same day or even within like 24 or 48 hours, you're not gonna know what caused it. So only for that reason, I like to separate it and just have a few days in between. But I would say in general, most of my patients, they don't just do one, they don't just do acupuncture. And if I do get a patient that only wants to try acupuncture, I always tell them that they need to explore, other modalities as well, other interventions. Because they all approach the same condition, but just, from different angles. And endometriosis is a difficult disease to treat. It has a lot of, complications, and just having all the different approaches, it really does make a difference. So it's at the same time, but just not on the same day.
I want to ask a question without making a comment. Am I on the microphone? Here, okay. So, there is nociceptive pain as a somatic or visceral. So the question was, why does endometriosis causes pain? So it's truly there's a visceral component of it, because endometriosis is a visceral disease of the bowel and peritoneum adhesion and retroperitoneal fibrosis. That's how it gets deeper and deeper to neuropathic pain. Can you explain the nociceptiveness of, this is to my good friend, Dr. DeGregoris. I'm asking you the hardest question. Nociceptive component of the visceral pain, the pain that comes from the bowels, organs, because these organs compete with each other inside. Pelvis, especially in competition with uterus, bowel, rectum, intimacy, if I may say, and the bladder. They all function differently. They all have different innervation and activity time. So when there's scarring between them, bang. That's how things get bad with respect to pain. This is the way I see it as a surgeon. The rest is when it's retroperitoneal, already the nerves are entrapped. Fibrosis, hypogastric nerve involvement, the bladder dysfunction, it's cul-de-sac, painful intimacy and painful bowel movement. Obviously, pudendal and sciatic, which we see as neuropathy, is very, very deep form of the disease. Many times, the way I see it, it's referred pain. We ask this question very specific to patients when they come to us. We have a pain questioning. Leg pain, is it in the front, inside? We know what those nerves are. And patients really pointed, and you look back, you see, for example, psoas region or iliac, they really, if laterality is such a significant thing in our interview, when I ask, is it in your one side and it's recurrent or persistent, I know that there's more disease on that side, and usually it is. So would you comment on viscerality or pain? And the second portion of the question is this gabapentin business. I have this thing against gabapentin, let me tell you. Don't get me on gabapentin, please. Ketorolac, beautiful, but I want your feedback on that. Sure. Because there's a lot of people, unfortunately, you see in your practice, and the public should be aware, there's chemical dependency, and patients are innocently being railroaded to that path. With some reason or another, it's in a month, it's history. They're gone. They want it more. And you can't blame them.
Two great questions, which we could talk a long time about both. But from a fairly high level, I think the first point of teasing out visceral pain from nociceptive pain is a good one to go through. So oftentimes, earlier on in the disease, people will have more visceral symptoms, like Dr. Skitchen first mentioned too. Visceral pain tends to be harder to localize. So you can't point to it with a finger. Usually you'd have to point to it with a whole hand. Visceral pain will oftentimes feel like it's deeper, perhaps is more localized to the pelvis, less likely to go south of the inguinal ligaments, which is the crease approximately in your groin, your hip there. And visceral pain tends to come on slower and perhaps persist longer in each individual episode than nociceptive pain. So nociceptive pain oftentimes comes on like a lightning bolt, may come off like a light switch. Visceral pain might come on slower and come off kind of slower as well. In terms of, so that's the other side of endo pain. In terms of opportunities for treatment, the non-steroidal anti-inflammatories are certainly, a go-to, and I would say, first line in most cases. Ketorolac is a good example of one. More familiar examples would be things like ibuprofen over the counter, which is oftentimes used for even very, very painful surgeries. When people have hand surgery and foot surgery, orthopedists really, really lean into the NSAIDs. NSAID being NSAID, non-steroidal anti-inflammatory drugs. The trouble is that they have side effects, but of course everything has side effects, right? So typically side effects are dose dependent. So side effects that we become concerned about for NSAIDs, with too much they can cause stomach discomfort, because it so happens that when you use these anti-inflammatory drugs that decrease these chemicals called cytokines. Some of these cytokines are actually protective in causing the cells in your stomach to secrete a mucus that protects your stomach from the acid. So yes, it will decrease some of the inflammatory mediators, but it may also decrease your own body's natural protection against the acid in your stomach. So it can cause dyspepsia, stomach discomfort, would be one common side effect that NSAIDs have. And that's why we don't put people on high doses of NSAIDs forever. But most people with healthy kidneys and livers can get away with a pulse dose of it, take a high dose for a few days, and then take a break for some time. And that's one strategy to try to mitigate side effects, although you're always going to have some risk of side effects. The aversion to gabapentin, I think, is very understandable, because gabapentin has a lot of side effects also. We know that probably the most troubling side effect of gabapentin is sleepiness, and a lot of patients describe word-finding difficulty and overall brain fogginess. And one of the troubling things about gabapentin is it's hard to know how much each person needs. It's a drug that has a very, very wide therapeutic index, which means one person might get benefit from 100 milligrams a day, and another person may require 3,000 milligrams a day and still not get any benefit, or may get some benefit at 3,000 per day. So how do you know where to start? Well, you start low and you go slow. So you start with a low dose, and if it helps, you continue it, and if it doesn't help and there's no side effects, you consider going up. But like I said, like Dr. Michitsch alluded to, everything has risk and everything has side effects, and a lot of people will describe sleepiness on gabapentin. It can interfere with driving, and you shouldn't drive if you're taking gabapentin, because it can slow response time. So then it's hard to become a fully functioning person of society if you can't drive, that's for sure. So there's lots of reasons to not use any of these drugs. Gabapentin would be one of them. There is a very small subset of people who may report addiction with gabapentin, although it's pretty small, certainly much less than opioids. But in some of the studies that drug companies submitted to the FDA for approval, there was a minority of drug addicts that did report liking gabapentin in a way similar to drugs of addiction. But it was a lot less than the opioids, to be sure. So I think in many instances, the benefits outweigh the risks of gabapentin. So it might not be a first-line agent, but it's still on the list, I think, at some point. And it can be helpful with both visceral pain and nociceptive pain, to try and tie back to the initial question.
I just have a comment too.
Please.
So like in PT related to that question, so there's two things I can think of like right off the top of my head. So a patient comes in and they have pain with insertion during intercourse. We're treating that patient, we're treating all the muscles, and and we've done everything, and they've been coming in a long time, and they're still telling us, okay, every time I have intercourse, I have very, very deep pain. That's when we would think, okay, it's not just nociceptive, it would be more visceral, that there could possibly be endo in the vaginal rectal wall. So we're treating them for a while. In the time frame that they're coming in, it should have gotten better by this point, and they're still having those deep symptoms. I would say it's more visceral. Someone that comes in, that just comes in with a complaint of pain with orgasm. Pain with orgasm could be muscular, right? So they could have hypertonic pelvic floor, and when they have an orgasm, it spasms, right? So we're treating them and giving them all these treatments for orgasm pain. But if none of those treatments work over a period of time and they're feeling it very deep into the pelvis, we're thinking, okay, maybe this is coming from the uterus, maybe it's adenomyosis, so that's when we think more visceral. So sometimes it does take time for a patient to come in that we're going to determine the difference too.
Can we open up the floor for a couple questions now?
I think you were first. You were second. Hi, my name is Amy. Thank you for your time and all this information. Speaking about, we were just talking about different drugs, what can you tell us about the use of medical cannabis for pelvic pain? And what advice would you give patients in terms of researching that if they think that that might be something they want to explore?
So the question, I think everyone heard it, is what role can medical cannabis play in addressing pelvic pain? And I think in a quick phrase, I could say certainly an ever-increasing role in the future. I foresee it becoming more and more a drug that's tried earlier on in the pathway, as opposed to right now. It's kind of certainly most professionals think of it as a drug of last resort, but it's coming up in our algorithm. And the reason why it's a drug of last resort is a couple-fold. First, of all the drugs that are out there, it's by far the least studied for a variety of reasons. I think that's the most important one. So it has the most unknowns about safety and side effects. Another reason is that it's not really one drug. It's really hundreds of compounds that typically are used together. So we know that the two most important ones and the ones that have been most studied and most cited are THC and CBD, which people have given day-long talks on the differences between the two. But globally speaking, they both are centrally acting compounds. THC tends to have more of the psychoactive components, and CBD, for the most part, has little to no psychoactive components. And I think one of the reasons why it's not thought of earlier is because people think have a lot of negative stereotypes of the psychoactive component of it and don't want to be labeled that way or seen that way. And I think a lot of physicians don't want to feel like they're pushing that on people. But I think the CBD component for sure provides an enormous potential for the future for treating these things aside from all the psychoactive components. So I think there's not a lot of great data on it, but I think the first step is to talk to really any providers like this, because people on the stage, we all know people who have used them. We can share experiences with where we've seen it help. And the process to get it is becoming more streamlined. So now there's, I don't know how many, but there have to be hundreds of providers in Manhattan who now have licenses to certify someone for medical marijuana in New York. And then you go to a dispensary, which that in of itself can be overwhelming. But there are a variety of choices there. And again, these compounds are not one particular compound that you're getting. So typically you're getting at least a few things. But it's on the order of a certain number of milligrams of THC and a certain number of milligrams of CBD in various combinations. But that's how you sort of get started, is you talk to someone like this, then you go to a provider to get certified. If you're thinking about it, I think at the very least it's worth talking to a potential certifying provider. I am not one, but there are many in the city who are, because these people know the most about it. And I think it's worth at least talking to one of these certifying providers, and they can give you realistic expectations. Here's what it can do, here's what it can't do. Like most other medications, I think it's definitely not going to cure the problem, I think it's going to be a small but significant part of treatment.
And we will see, I don't know, Mindy, if you want to say something, sorry, but sometimes we'll see in Lexi, like the first wave of like CBD, THC came about, I feel like 5 years ago with us treating, and a lot of patients we've found, sometimes if patients come in, I know Dr. Session has an opinion about this, like they're already using Valium suppositories to help their pain, right? And they don't like it, or they've been on it a really long time, and it's just not a great drug to be on in general. So we have found that certain patients, not everyone, it's definitely a specific patient, could benefit from maybe using like a CBD suppository, which could really provide the same relief as Valium and have different effects on the patient. So it totally is patient specific.
Hi, thank you to everyone on this panel.
I was like, I shouldn't say this, but this is what we say.
What about other things I'm really curious. Have you seen practitioners using other than Valium, like Botox, Viagra, they use either?
That was also my question about Botox.
That was her question also.
On Botox.
Is it part of the practice that you see around? The vaginal Viagra or Botox? And
Yeah, we see.
how effective are they? I mean, what's your experience with respect to its feasibility and use?
I think and I know you guys could probably all agree, it totally just depends on the patient. Some patients love Valium suppositories and it relieves their symptoms, and some patients, it doesn't do anything for them, or it gives them diarrhea from just putting, a suppository in, but.
Bottom line, it goes to the system, right? Just, basically taking it local, it's like vaginal estrogen therapy versus oral estrogen therapy. So the effect and it's staying in the bloodstream is different probably when it's given from. I could understand that, but you find that useful in some patients post-op.
Depends on the patient, I guess. I know that's not a good answer. I don't know if you guys have another.
I think sometimes it knocks them out, it helps them sleep better, and
yeah.
like, is that actually what is helping them? It's
To be honest,
also sometimes it's hard to
surgical
wean them
group,
off
when
it.
it comes to endometriosis.
Yeah.
Let's talk about endometriosis.
Yeah.
I am very, very careful when I have patients who are already taking very routinely pain medication, especially opioids, because I like to be helping to patients, and sometimes my success rate gets limited because I cannot differentiate. This is the biggest challenge I have. I'm extremely careful. I don't deny treatment. However, prior to treatment, I make sure they see the proper physical therapist. There's some degree of involvement, maybe pain medication doctor, that's like Dr. DeGregoris prior to surgery. I want to format a very transparent, honest relationship with these patients, because sometimes you really remove the whole disease and you think you did such a great job and the patient is not better. And there's other reasons for pain continues. So I think it's important to have the right proper consultation with these patients when you select patients. It's very, very challenging subject. Many patients are taking, some significant, I don't know the numbers, to be honest with you, but I guess it is not very little. I can tell that. Would you agree with pelvic pain patients on some sort of serious medications they take?
I mean, I think it's less, we're not seeing as many opioids. And
You're right on that.
Yeah, and a lot of times patients are trying gabapentin and they don't like the side effects, right, because of the fatigue. But I think that there's a lot less. We never really see oral Valium, I guess, because it's addictive. We'll see more vaginal Valium, but not everyone likes it. And then a lot of patients that really don't want to be on any meds will go to CBD and THC.
I think there's serious awareness on the
Yeah,
subject. It's
there
getting
is,
better. You're
yes,
right.
and a lot of
Yeah,
physicians are really
definitely.
not prescribing it.
Definitely.
But like, for instance, like a patient that I've shared with Dr. Sechkin, like he did a big surgery on her. She had a lot of stuff removed, and she still was having the same exact pain in a specific area. And he sent her to PT, and it was really just muscle and adhesion. And, so that's someone that if she didn't go to PT, she might have went to another physician that would be giving her opioids or something. So I think it's super important just to be aware that you should try acupuncture or pain management or pelvic PT before you're going to any sort of serious drug.
Yeah, and actually with acupuncture, you're getting natural opioids. So it's just, so it should be definitely something that, one should try. And then also it's important to know that there are different styles of acupuncture. So even Mindy and I practice a little bit differently. So if you tried it and it did not help you, don't give up on it, but, go to somebody else, maybe a different practitioner, maybe somebody who's more experienced in treating pelvic floor or endometriosis, and, maybe a different approach would be more helpful for you. And then also if you're willing or if you're thinking about getting Botox, you can actually needle the same way into the pelvic floor muscles as, Botox, but it's natural. When you're needling, you're able to release tension in the muscles without having to inject anything. So that's also an option.
I just wanted to make sure your question was answered. Okay. Oh, yes.
Hi. Good afternoon. Thank you for all you do. So this question is for everyone, but especially for Dr. Gregoris. Is the block that you're talking about, because I work with a spine doctor who does bilateral superior hypogastric plexus block. Is it the same block that you're doing? And if it is, how effective it is with regards to patient pain relief of the patient?
Great question. So the question is, what kind of blocks are we talking about? The superior hypogastric plexus is one opportunity for a nerve block. It all depends on where you think the pain is coming from, which is largely driven by the location of the pain, and that's a very common block to try. The blocks that we often do for deep visceral pain, as opposed to nociceptive pain that might be facilitating this wind-up, addressing this wind-up, are addressing the sympathetic nervous system, which is a little bit different than your somatic nervous system. The somatic nervous system is what you think of when you think of everyday nerves, the nerve that moves my arm, the nerves that makes me recoil from pain. That's somatic nervous system, that's somatic symptoms. The sympathetic nervous system is a more primitive nervous system that has more to do with visceral style pain. It's not well localized. It tends to be broader areas, and it may come on slower, come off slower. It oftentimes is more dull or achy as opposed to sharp or stabbing. So if you think that some of those adjectives apply, then you might think, okay, a sympathetic block might be appropriate. And the one that you mentioned is an example of a sympathetic block. That's among the most common one. Another commonly performed one is the ganglion impar block, which is a different set of nerves, part of the same nervous system. I think that is your question.
We do find with the endometriosis population, the ganglion impar block is what we start with. Is that, yeah, it could be super, super helpful for the patient. Yeah. What does that mean? It's just that if we're treating the patient and
What is it?
oh, the ganglion impar. Oh, yeah. So we'll so say the patient's still having a lot of pelvic pain. I'll say, okay, Dr. DeGregoris, can you see this patient? Maybe they need a ganglion impar block, and you could describe exactly what it is. Yeah.
So the ganglion of impar, a ganglion is a type of nervous cells, so it's a collection of nerve cells. And then impar, I think it's an anatomist's name of some person who attached their name who first, I think, dissected it probably in a cadaver or something like that, or maybe it's a physician's name, I don't know. But I think it's someone's name. So it's the ganglion of impar. And it's one location in the sympathetic nerve system that provides opportunity for treatment of pelvic or urethral or vaginal pain. So it's a type of nerve block. It's a specific location, and it's one of the, it's a good target because it's fairly superficial to the surface. You can get to it without causing a lot of collateral damage, without irritating other things, and it oftentimes can provide benefit if that nerve is indeed causing pain. So it's diagnostic as well as therapeutic. If you think this nerve might be causing pain, you block it, and the pain may get better and it may not. If it does get better, then probably that nerve was at least causing part of the pain.
Okay, thank
Right?
you.
So like we're working on the muscle and then we're like, okay, the muscle's good. Let's check the nerve.
It's at the very bottom of the spine, near the tailbone. Yes, it's part of the spine.
Okay, one more.
Yeah, can one still benefit from these modalities that you offer if they've had the surgery, say, 3 years ago and did not go into any therapy that you offer?
Certainly with the pelvic PT, we see people 3 years, 10 years, very long after surgery. They can still have scar tissue adhesions we can work on. They can still have discoordination of the pelvic floor that could be causing a lot of pain, even muscle spasms in the pelvic floor that could be causing a lot of pain. So yeah, we see people far out from surgery.
Also, like bad bladder habits and bowel habits could make the pain even worse. So even just like focusing on that and that's, could come anytime, 10 years after surgery. So yes, definitely.
Thank you so much. That was incredibly informative. Really appreciate your time.
Sure. Thank you.